The disease we'll be discussing today is oral lichen planus. Lichen planus is a chronic mucocutaneous disease with oral lesions most commonly in women between 30 and 60 years of age. Characterized by a typical presentation of bilateral white lesions occasionally associated with ulcers, persistent in nature with a possible relationship with squamous cell carcinoma. Various types: the reticular type, erosive or ulcerative type, plaque, a papular type, and erythematous or atrophic. Lichen planus has various cutaneous and extraoral mucosal sites of involvement, but the intraoral sites affected by the disease are gingiva, palate, bilateral cheek, dorsum of the tongue, ventrolateral surface of tongue, and the vermilion. To know the cause, let's get familiar with the cells involved in the disease. The basal cells, melanocytes, Langerhans cells, and the lymphocytes, CD4, CD8 T cells. On antigenic stimulation from any dental material, stress, drugs, or infectious agents, there is an activation of the Langerhans cells that causes upregulation of endothelial adhesion molecules like ICAM1. This results in the recruitment of CD4 and CD8 lymphocytes that gather at the dermal-epidermal junction, and by the secretion of various cytokines causes basal cell destruction and results in basal cell vacuolization and formation of apoptotic civet bodies. Let's see a larger picture to view many other diagnostic changes in the epithelial structure resulting from lymphophagocytic infiltrate at epithelial connective tissue interface. There are sawtooth-shaped retiridges, basal cell zone vacuolization along with apoptotic keratinocytes called the civet bodies, and hyperkeratosis. Reticular lichen planus. The most common variant, mostly asymptomatic and usually involves the posterior buccal mucosa bilaterally. What you see is Wickham stria, which is a fine lace-like network of white lines over an erythematous background. We talked about melanocytes as one of the cells involved in the disease. Due to its presence in the basal cell zone, it may cause post-inflammatory melanosis which may accompany the reticular stria. There is a characteristic waxing and waning associated with the disease. The lesion is not static and may increase and decrease in size over a period of weeks or months. Erosive lichen planus, which is the second most common type and symptomatic due to the fact that there are atrophic erythematous areas with central ulcerations. The periphery of the atrophic region may be bordered by fine white radiating stria which may be seen. How to diagnose? The diagnosis is based firstly on the clinical outlook of patient, presence of Wickham stria on an erythematous background or surrounding an ulcer. Secondly, perilesional biopsy for light microscopy which reveals sawtooth-shaped retiridges, basal cell zone vacuolization, apoptotic keratinocytes called civet bodies, prominent granular cell layer, and hyperkeratosis. Thirdly, perilesional biopsy for direct immunofluorescence reveals fibrinogen deposits are observed at the dermal-epidermal junction that exhibit a shaggy paint running pattern. Treatment includes corticosteroids in the form of topical application or intralesional injection. Systemic steroid therapy is reserved for severe cases, while an addition of an antifungal to the regimen helps eliminate any secondary Candida albicans infection. The systemic and topical vitamin A analog, the retinoids, have an anti-keratinizing and immunomodulating effect, while topical calcineurin inhibitors such as tacrolimus are reserved for steroid-resistant cases. Ending with the hope that it helped you in one way or another.